hard on this presentation. She's been doing a lot of research, a lot of revision to these slides, and I'm very excited to have her with us today. So Carolina, the CNN Network.
Well, thank you. I always feel like Leon makes like a huge introduction, and then I'm not gonna like meet expectations. But here we go. So we are actually very excited, not only about like the plan selection highlights that we're gonna go over. So hopefully things make a little more sense, and it helps you prepare for open enrollment. But we're particularly excited about the enrollment database updates, and we have here Jonathan, who's going to be doing a quick walkthrough. If at any point you guys have questions, especially if you just joined the network, if you have questions about the database, let us know and we'll help you understand it or answer any questions that you may have. Then we're going to go over some plan selection highlights, and similar to like the previous months, I am not going to go over the state's actual PowerPoint presentation because obviously it's there available for you to see. I'm just going to point out some things that, you know, as I watched that training, I wanted to make sure that we were clear on. And then just some quick tips on preparing for open enrollment, and then we're going to go over marketplace updates. So this slide I sent, I believe, last week in the middle of the week, and you can access, you know, obviously there's the link for the enrollment database, and everyone should have this information. If you have new staff coming on board, they're going to need a username and password. You can contact, if you're part of the CNN network, you can contact Leon. If you're from the New York State Health Foundation, you can contact Flor. So the primary database changes that happen were the ability to be able to track new enrollments, renewals, and qualifying live events. And the other big change was on the notes section. You will now be able to enter a specific date for different notes. And that will be very important because many of you, and I should say that a lot of the changes were based on immediate feedback we got from all of you. You guys pointed out the things that were missing on this database. Maybe there are some additional things that you were thinking would be great to have. We always have to balance on not being over-inclusive because this can be a daunting task, and we want to make sure we capture enough information, but at the same time, we don't want to overdo it because it can be time-consuming. So again, Jonathan will go through a walkthrough. The household tab, which is where you're going to put the head of household information, stay pretty much the same. I do want to remind you that when the head of household is also applying for coverage, you want to select that they are applying for coverage, so their information is populated. The funding source, which is right below the red box there, is very important. If you're with the New York State Health Foundation, you want to select a New York State Health Foundation Enrollment Network. If you're with CSS through the Navigator program, you want to select CNN. And you want to do that because you want to be able to account for the right funding source. If you have both a CNN grant and a New York State Health Foundation, it is even more important for you to be able to allocate which cases are going to which grant. The next tab, this is where a lot of those changes occurred. So one of the big changes is adding a service, and that service is being able to add another application service detail to a client. So let's say that you are seeing a client that is coming back, you would click an add service or go to the service detail page, and you will be able to report the type of service. And again, Jonathan is going to do a walkthrough, so you have the slides. And at the bottom, you can see that your notes are going to be ordered chronologically, and it's going to have a date. One of the things the New York State Health Foundation wanted to do was to be able to track all the casework that you are doing for clients. So this applies to everyone who wants to be able to use this feature, but specifically for the New York State Health Foundation, if, you know, depending on your agency, you may actually be seeing clients that have a very heavy management load. And so this will be a proxy for you to be able to track that. And CSS will be able to report to that foundation the number of notes. And again, that will be a proxy for the amount of time. And so we would count the number of service dates. I would be judicious with it. Obviously, this function and a lot of the features on the database are for your use, and we want this to be a tool that helps you manage your cases, especially with the next open enrollment period. I cannot even imagine some of your dashboards are going to be crazy, and unfortunately the dashboard through the marketplace may not have all the functionality you need to keep things straight, so hopefully this database will help you do that. But again, you want to be mindful on your notes. You know, you might not want to enter an entry date if you return a call to the client. You might just do one combined. The client called, you return the call and you address the issue, right? As opposed to having 3 to 4 just for that one issue. The application recertification status will stay the same, so we will have complete, partially complete, and information only. As a reminder, a complete enrollment or renewal or qualifying life event means that that individual got an eligibility determination. The big change that we added is the type of service. So now you will be able to say this is a complete new enrollment, this is a complete renewal, this is a complete qualifying life event. Or, you know, if the client comes back for renewal and you couldn't complete it because they decided not to proceed, you will have partially complete renewal. So you will be selecting the fields that apply to your specific case. At the bottom in the enrollment method, that's really useful and important to select because we are using that for a state report. For the New York State Health Foundation, this is not going to be as critical. We encourage you to use it because I think it's useful information for the New York State Health Foundation. It's almost a require. We're not making it a require field because, again, we want to make this user-friendly. But when CSS is reporting to the state your navigator activities, they ask us how many people were no-shows, how many enrollees were done through an appointment, how many were walk-in. And it could be that for the same client, you know, you schedule an appointment, they didn't show up, and then they eventually just walked in, right? So you select as many as possible. And the idea is for CNN, again, is to not have you do the survey monkey. It's for you to be able to track all this information and for us to be able to pull that information without really asking for additional stuff. And I just went over that slide, and type of service, again, no major changes. So Jonathan is now going to do a walkthrough.
Hi, everyone. So a lot of you have done hundreds of applications already and are very familiar with this database. But some of you also are pretty new and may have never done one before. So I'll try to keep it relevant for everyone here. And feel free to write in questions if there's anything I'm not addressing that you are uncertain about. So the first thing you want to do when you have a new client is click on Add a New Household. That's in this first screen, which is also the search screen, and the list of clients you have. So these are my state clients. Up here you could search by client ID, last name, date of service, etc. So you click on Add a New Household. You would enter the head of household's first name, the home address. These aren't required, not because we don't think they're important, but because we, as Carolina was saying, want to make this as user-friendly as possible. The more information you put in, the better, not just for us, but also for helping identify clients when you might have forgotten their name, you remember where they're calling from, etc. So enter the city, state, Zip code, county is required because it's one of the important non-identifying fields that we need for reporting. So enter New York, the email if you have one, how they prefer to be contacted either by phone, text, or email, what language they would like to be contacted in. We're going to skip this one for now, but I'm going to come right back to it. How they heard about us be by, we'll just select that. Funding source, you're almost definitely going to be selecting either CNN or New York State of Health Enrollment Network. We'll just select that one for now. And this one is important, not just for record keeping, but also, as Carolina just mentioned, because if you select yes, it saves you a step in the next screen, and then you don't have to re-enter this information for the head of household, that is. So we're going to click Save. Oh, sorry. And this is mostly for the New York State of Health, but there's also it also provides some valuable data for the CNN agencies as well. Is anyone in the household an LGBT, immigrant, low-wage worker? And if low-wage worker, we have their industry. So when you're done with household information, you can navigate over to the sidebar, and we see the next screen is consumer information. We'll see some things that are different here than the old version of the database. But since I clicked yes for his head of household applying, all that information gets brought over, and we don't have to enter that again for Joe Miller. And if he is applying with his son, we would go down and click Add. It gives us the ability to add other members of his household. So let's say son's name is Mark Miller. His relationship to his head of household is he's the child. His year of birth, age range, gender. As you can see, all of this is not required, but also provides valuable information. Okay. You click Save, and it's populated at the top under the consumer left. So we see Joe Miller, and it's on Mark Miller. So one way to proceed from here to the service details, which, by the way, is the combination of the third and the fourth screen. If you're not a new navigator, you might remember that we had the application details and the assistance provided screens, but they've been condensed into one screen for convenience. So you can either click on the side, or we have this new thing. This is also a reason we recommend to use Internet Explorer and not Google Chrome, because it is highly optimized for Internet Explorer, so some of the functionality might not be ideal. So you'll see the Add Service button is a little bit compacted. So you can click on Add Service, and it'll take you to this screen. So this is for Joe Miller, as you'll see at the top, not for his son. So you could select the date of service. We'll say he did a complete new enrollment. Okay, let's say renewal. And qualified health plan. You obtained some cost sharing reduction. You got a silver plan and full APTC. So alternatively, these grayed out boxes will be populated or populatable if you select partially completed, you'll have the partially completed reason box open. You'll have the Child Health Plus box if you select Child Health Plus over here. And a message to the state will be populated if, where is that?
It could be if it's incomplete, but then you, so this is the space that we would like you to use whenever you have an issue that you want to report to the state, so you can write it here. So for example, the issue that we were discussing about client was dropped from a couple's plan when Medicare, when spouse became eligible for Medicare, something like that. And you can use these later to report it to the state whenever there are issues, like to us. Yeah.
So the next box is the enrollment method. Carolina discussed it and how you could potentially be selecting multiple. For example, if a client scheduled an appointment, it took 3 days to get him in. He ended up being a no-show. You're unable to reach him. But then he also rescheduled an appointment for another time when he realized he missed his appointment. So you can select one, you can select multiple, depending on the situation. And down here we have what was formerly the assistance provided section, and it's called type of service. And we have all the different options, including non-marketplace renewal, which is specifically for the New York State of Health Foundation paper renewals.
Yeah, so I want to explain that and who's going to be using that. So for all the navigators, you would not be clicking that non-marketplace renewal because those refer to the paper renewals, and for our grant, the state has been very clear that they do not want us to be completing those HRA renewals, right? So you would use the top part that Jonathan just went over and do the recertification part, meaning, you know, complete or partially completed, and so you would use that to report any renewals you are doing through the marketplace. For the New York State Health Foundation, some of you are doing paper renewals and have been doing paper renewals throughout this year and will probably continue doing paper renewals. The New York State Health Foundation allows you to do that. But whenever you have a paper renewal, you would not select recertification on the top, and we'll send instructions in writing so this makes sense. Instead, you would just select non-marketplace renewal. So again, for paper renewal, and this only applies to the New York State Health Foundation, on the top, if you help a client who came in with an HRA renewal app or LVSS, you're going to select complete, and then you're just going to scroll down to the bottom and select non-marketplace renewals. And the reason why we're doing that is because the foundation wants to differentiate between renewals that you did through the marketplace or enrollees through the marketplace and paper renewals that you continue to do. They see that your work is important in the sense that they don't want you or prevent you from reporting paper renewals, but they want to be able to track those two numbers differently, to be able to say this were how many paper renewals and this were renewals through the marketplace. Again, we'll send you instructions for the New York State Health Foundation on that. CNN, I don't expect you to be using that at all.
So after we finish this section, we can click Save. And then it allows us to do Add, which is the main functionality of this whole change, being allowed to add multiple consumer services to this list. So the same way we added multiple people to the consumer list, we can add multiple services to the consumer service list just by adding Add and adding a second service date.
Mm-hmm. And that way we will be able to, for reporting purposes, we will be able to identify that you helped one client last year with their initial enrollment and that this year you also helped them with the renewal. So we will count them as two cases.
Yeah, so let's say that same client, okay, you helped them last year with their initial application. They come during open enrollment to do a renewal, and let's say it's March of next year, and they have a life change event, and they come back to you. You're going to add another service date, and you're going to say complete life change event. And again, whenever you're using the type of service, which is new application, renewal, or life change event, that means that they're getting a new eligibility determination. And the state is counting those separately. So it could be the same client, and every time you get an eligibility determination, they are counting those as separate, more or less, applications, even though it's one consistent application or one client. So this is kind of like the best feature, I think, of this database update, that you are now able to track multiple eligibility determinations that you are having with the same client.
And keep in mind, this whole time we've just been working on the father. There's still the son. So just by filling out the father, that doesn't mean that the son's information has been filled out. So you go back to the consumer information, click Add Service, and you fill out whatever is appropriate for the son. So you fill it all out, fill out any other information that you need, and you click Save.
And this allows us to count each one of your enrollments, to count each one of the people that you enroll, and not necessarily like the applications that you complete. So that's beneficial to you if you add the household members.
But only those enrolling.
Right.
Sure.
Yeah.
And just to take a quick look at the new notes box at the bottom, when you add a new note, it gets timestamped and says who wrote it based on who's logged in. And if you add a second one, it comes up on top of the previous one. So the most recent one is always going to be on top. Them if they're a mistake, or edit them if you want to go back in. And that pretty much covers it. I'm going to take a look to see if there's any questions and to see if there's any hands up. So the PowerPoint will be available after the webinar. Carolina just stated that a complete enrollment is an eligibility determination. Does that mean it's complete if they don't submit or pick a plan?
Well, that is a great question. You guys are paying attention. That is great. So and this issue has already come up, so I'm glad whoever wrote that question brought it up. So for Medicaid, remember, if you get a Medicaid eligibility determination and you don't pick a plan, your client will automatically be enrolled in a plan, right? Assuming they're not staying with straight Medicaid. So it will depend, right? If for straight Medicaid, if you've got straight Medicaid, there's nothing else you're going to do, you won't select the plan. So that's a completed. If it's Medicaid with a managed care plan, even if the client doesn't select the plan right there and then, they're going to be automatically enrolled unless they retrieve their application, which hopefully you would know if that happens. But for a QHP, a completed it's really plan selection. The state is actually keeping track of both. They keep track of how many eligibility determinations you got and how many people actually selected a plan. So the short answer for a QHP, you have to select the plan to be deemed completed. The state is keeping track of both. For our purposes, again, if it involves the QHP, or even Medicaid, it's plan selection, unless, again, that's not the case for that particular client. And that also includes for emergency Medicaid, right? Like they'll never select the plan, so that would be a completed.
So is the New York State of Health number required? No, it's not required, but it's just useful for helping to identify your clients because you could search by that also. Before the year of birth was entered automatically, and now we have to enter it. So the reason for that is because we can't ask for the month or the day anymore, and since we can't ask for that, it might assume incorrectly depending on what month of the year it is and what month his or her birthday is in. So if he just turned 19, but it's the same year, it won't know to carry it over because it doesn't know when his date of birth is anymore, just his year. So we have to actually ask you to enter that yourselves. Is the message to the state function in addition to submitting a case report, or will it replace the case report?
The idea, I think, when it was created is that it will replace the state reporting form. But with that said, obviously the text box in there only gives me the issue. We can, moving forward, I'm going to do some brainstorming with Nora. My concern is making sure that obviously I have Jonathan run the data consistently for me to know those. So I'm actually working on the case reporting form. There's some things that we're going to have to change how we do it, in the sense that, you know, you guys submit very compelling cases, and we do report them, but it seems like that when we report too many, even the urgent cases are not getting the immediate attention that I believe they should be getting. So we have to strategize, and that's my work, right? Like, figuring out how best we're going to process those cases. We did send out an email about 2 weeks ago letting you know that we're going to reach out to you, meaning those who have reported cases, to confirm whether some of those cases have been resolved, because we never got an answer from the state necessarily on some of them, because we want a fresh start. So the idea would be to have only the pending cases, for me to prioritize them and send a clean list to the state and say, you know, prior to open enrollment, which of course is a very close turnaround given that I have a week and a half, we want to make sure that we really limit any outstanding cases. So give me a little time to figure out how we can best use that feature. But for now, don't rely on that feature. We'll eventually try to make it work and create a smooth process.
If a client qualifies for Medicaid and they have employer health insurance, Medicaid may pay the premium on the employer plan. How is this connection made?
So when you're doing a Medicaid application or any application, the application will ask you, does the person have health insurance? And it will ask you for specific information about that health insurance, including the cost of insurance. I haven't seen a case where Medicaid pays for it, so if anyone has that example, let me know. But in theory, you put in the amount, or the client puts in the amount, and then the application or the system should be able to figure out whether it's more cost effective for them to pay the premium of the employer-sponsored plan as opposed to paying the premium for Medicaid, right? So let's say that the employer-sponsored plan, your portion is $20, right? That may be more cost-effective than the state paying the Medicaid premium. But the system is supposed to be able to do that with the information the applicant inputs in regards to cost. So it's important to put the right amount. Again, I haven't seen personally any clients where that has been the case. Usually Medicaid just acts as secondary.
So if a client's application through the marketplace was sent to their local DSS to enroll in Medicaid, this is considered a complete application, even though it's ultimately going through DSS?
Nope, that would be partially complete because you did not select the plan there. And what you would do at the bottom on the service details, you would select that that was referred to the local LDSS. And just so you know, for CNN in particular, when we're doing an analysis of your enrollment numbers, we actually look at both completed and partially completed enrollment. We understand that, you know, sometimes you spend more time with a partially completed enrollment than with an actual enrollment because something obviously went wrong with the partially completed. And when I say something went wrong, it may simply mean that the client didn't want to continue, or it may mean that you had to go back and forth with HRA or figuring it out. So just so you know, we do take into consideration your completed and partially completed, but for record keeping, that would be a partially complete unless you selected a plan, and you would select refer to HRA LDSS.
If a client gets QHP eligibility but doesn't pick a plan because they want to think about it and do that later, do we enter a partially complete and then another service when they make their choice and complete?
No, so just one. So if you're going to have to wait and confirm later on, so if the client has access to their application and they're going to say, well, I'm going to go ahead and select it, just keep tap of that application, and then maybe at the end of the month when you know that by that time they should have selected a plan or they should have let you know, you can confirm the end status of that application, and you do not add a service date. Again, if you added a service date, that would mean that two different things happen when in fact it's just one set of services, right? It's one new enrollment, one renewal, one qualifying life event.
Mm-hmm.
So you might have just answered this one also, but Carolina, can you clarify, if someone gets a Medicaid eligibility determination but isn't yet ready to pick a plan, can I go ahead and put it as complete, or should I wait and see if the client selects a plan?
It's a judgment call, right? I would only be concerned if the client seems to be not wanting Medicaid and they express that they might retrieve their application, which, as you probably know, is probably very hard, meaning you have to either rerun the application or call the marketplace. So it's really a judgment call. Again, if you have to wait to make sure that if, usually you will know that prior to the 15 or within 10 days, they're going to be automatically enrolled. So again, I leave it to your judgment. You'll know when to do it. Obviously, your objective is to have as many complete entries as possible. Well, I can say it.
Okay, there was a couple of questions about why we're no longer auto-populating the year of birth based on month and day.
Yeah, so it used to be that you would put it in the year. So let's say I was about to disclose my own age. Let's say you put 2000, right? So that will give you an age range. Unfortunately, depending on when you did it, it would send potentially those individuals into the bigger bracket. So for example, someone is turning 19 in November, and you put in the year, it might jump them above the category where it says 19 and younger. Anyways, what was happening, it was automatically putting some of them in the wrong age category because you need the actual date of birth in order to get the exact age range. I'm not sure if I'm making sense, but without the actual date of birth, November 31st, 2000, again, it's just putting some people in the wrong category, so we wanted to avoid that. If that still doesn't make sense, shoot me an email and I'll give you an example.
Can you include a not eligible option under the application recertification status tab? In addition to complete, partially complete, and information only.
So for that case, if you go and select partially complete, there should be a reason for why it was a partially complete. And what we can do, which may be easier, is if something there is not listed, I know that we were supposed to add that a client had other coverage or did not qualify. If there's something that you want us to include there, we can do that. Let us know if that answers your question. So whenever you have a partially complete and the client for whatever reason did not qualify at the end, then you would select partially complete, and you would mark the reason. This is not an exhaustive list in terms of the reasons. So the earlier you let us know what we're missing, which may be many things, we'll do our best to add it in.
Are you able to pull client history based off date of service regardless if you add a note below?
Okay, give me 1 second to see if I can figure out the question. If not, we might ask you to raise your hand so we can unmute you. So we got a question, and I may not have understood it correctly still, but it seems like, can you pull up a client based on date of service? So you're going to have your date of service, and you're going to have different dates for the notes. Those are two separate things, right? So whenever you're searching, whenever you're using the date of service search, that's based on the actual main date that you're entering for that client, right? So if the client came back to renew today, let's say, you would be able to search by that date. If you entered a note for that client and it also was today, we're not linking those notes to that client. And raise your virtual hand if I am missing the mark and I am not understanding your question.
And one last question. If a note is entered on a date other than the enrollment appointment, should date of service be today's date, whatever date the note was entered?
No. Your date of service is pretty static, right? Your date of service should be associated with your new enrollment, with your renewal, or your qualifying life event. Your notes could be one every month. They do not have to be linked. So it's very important for us to understand that. And the reason why we're doing that is because at the end of the month, we have to generate a report. And the most critical part is knowing how many enrollments were done. And those could be new enrollments, renewals, or qualifying life events type of enrollments per se, right? So the notes are yours. They are meant to help you, and we hope that they do help you with case management. Again, at least for the New York State Health Foundation, we're going to be using that as a proxy to get an idea of how much case management some of the agencies are doing, specifically because they're serving specific populations where it may, in fact, and the data will show, depending on how it's being used, whether that's in fact the case. And just to say, I know that you guys do amazing case management for every enrollment. I mean, I cannot think of an enrollment where you at least didn't have to do 2 to 3 different points of contact to complete it. And obviously, as they're calling you back, you've probably already made 2 contacts at least for one specific client returning.
Greg, did you want to clarify your question? I see you put your hand up.
Yes. So if I meet somebody to do an enrollment today, the date of service will be November 4th. It turns out, let's say, to be a partial complete, and then next week on the 11th they return and we complete it. So I'm going to go in and change partially complete to complete, but do I change the date of service or do I leave it where it originally was?
You leave it, and that's a great question. Yeah, you leave it.
So the date of service is really for CNN purposes only? Like, is it the date, the month where we anchor the application or the renewal? So if we know that a service, and by that we mean a renewal or a recertification or a life change event, involves multiple actions, right? And it could be services that are provided through a month, for example. So if you put it today, Greg, that will anchor the application on what day is today? On November, right? So when we run the numbers of enrollments for November, you will have that application credited towards November. But it's really
Even if I finish it in December,
yes.
so let's say.
Yes.
Okay. And that's how it's always been. So in other words, my reports may not show the enrollments I actually did in a calendar month. I might have started it in a previous month and gotten partially complete. But you
yes.
know what it is. And that's how it always was. Right?
Yeah,
Okay.
that's correct. But now the notes can show us that you will be able to show through the notes that you started it in November and you finished it in December.
Potentially, if you're updating them. But yes, Greg, that aspect, it stays the same. And, you know, one of the things with the service date, remember that we were only dealing primarily with new applications, so we always said your service date is the date you started the application, right? And that's kind of an important date for you to keep on record, because on the marketplace, you sometimes don't know when you started the application. So that would be helpful to know, especially when, let's say, you have Medicaid clients. You want to be able to know when you started it, because then you can argue for retroactive coverage and so forth. The other thing that we do on an ongoing basis is every month we're going to see your completed and partially completed. That's why I said that we really count and look at both partially completed and completed, and we know that the numbers are going to change. So, for example, September numbers, we may have 100 completed and 20 partially completed. November, maybe if we run the data again for those dates, we may have 110 completed and 10 partially completed. And that lets us know that the partially completed, 10 of them were eventually completed. So we're always running month by month and cumulative reports at the same time. So
I guess I still am a little unclear that, okay, if let's say I have an initial phone call with someone to schedule an appointment, I like to enter their data right away in the system, but I'm concerned that my date of service is going to show as the day I first entered the data on them rather than the day I actually met with them. Does that make sense?
Yeah, it makes sense. So as Nora said, we're going to be counting. The only thing that is going to change is that, let's say you enter their information, and we actually do it here at CSS. Whoever's scheduling appointments usually starts and will enter it. We are not too concerned from our end. Whatever date is there, it's going to get counted. And we count it monthly and then cumulatively. For your own purposes, you might want to either develop a habit where you go back and change that date once you start the application if you enter that person's information. Or if you leave it there, you'll just know that it will be counted and may be counted for, let's say, October instead of September when you actually started the application. Not a big deal.
All right. Thank you.
Evelyn, you have your hand up. Did you have another question? Evelyn? No. Okay. And
we're going to take maybe a couple more questions, then we're going to move along because we still have a few things to cover.
And Elizabeth, you have your hand up. Did you have a question? Elizabeth? Guess not. Does anyone else have any questions before we move on with the presentation?
Okay, great. So we're going to move forward with the presentation. Thank you, Jonathan. I'm sure that it's always great to hear from people who actually work every day with what they're presenting on, which the database is obviously Jonathan's arena. Let's see. I am going to go over this session probably a little bit fast to stay on time. At any point, if you guys have questions, let me know, and we'll either stop at a natural point. So again, as I mentioned, the purpose of the plan selection highlights, it's not to rehash the presentations done by the state. It's more to be able to I guess highlight and make you aware of some things that I think are important or were potentially confusing. So if you have not watched the training, the last training or the last two trainings, please do so. A lot of this stuff might not make sense, and I might just manage to confuse you because I am working on the assumption that everyone has watched this presentation. So the state announced that for this year they're going to have a product naming system. And so they're going to have the name of the actual product, the metal level, whether it's standard, whether it offers in-network or out-of-network, pediatric, dental, dependent coverage, vision, and so forth. So it's important for everyone to at least have something related to whether it's this chart or the state's presentation, at least at the beginning, because it may be hard to decipher. For example, if you look at the top, Affinity Access Platinum Standard in Network or INN Dependent 25, you know that it's the plan name. That's pretty self-evident, right? Then the metal level is also pretty self-evident. Then the ST, you just have to remember it's standard plan, and then the INN, it's in network, and Dependent 25, that means that that plan offers dependent coverage. Now, one of the things that I was a little bit thrown off was the fact that they said dependent 25 when in fact it's meant to say that it includes dependents up until age 26, right? So just keep that in mind. I'll go over that rule in the next slide, but when it says dependent 25, it doesn't mean that at 25 that's it. It's all the way to 25, meaning up to 26. If you notice the second plan name, that really threw me off because when I first saw it, I thought high deductible health plan or something related to high deductible health plans that might be associated with an HSA account. So that completely threw me off, especially when you saw that there was like a 269, and then it turned out that this was in fact the plan name. And I was totally thrown off because this is not a plan available here locally, so I'm not too familiar with that plan. Obviously, the metal level was clear, silver, and I just highlighted the fact that NS is non-standard, and this one will provide out-of-network. And the dependent up until 29, that in fact is up until 29. It's not up until 30, okay? So that's kind of like, again, what threw me off of how they outline the dependent 25 versus the dependent 29. And if you notice the second one, it has a couple of things, right? The out-of-network and the dependent 29, those are going to be big signals to know that you're probably dealing with a small business marketplace product, so you might not really encounter it in the individual marketplace. And one of the reasons is, and again, I'm going to have to confirm, and I'm sorry, I should have had this information for you, is whether if there are any plans in the individual marketplace which offer out-of-network coverage. It means that obviously in the small business marketplace there will be some options. The other thing is that depending up until age 29 requires a small group plan. So again, you are more likely to see it on the small group market. So this is a reminder about dependent coverage age 26. So this is like federal law, and this population, the young adult population, have greatly benefited from the Affordable Care Act. And the rule is that, I hate to say kids or children, but dependents who are able to be on their parents' insurance can stay enrolled up until age 26. And it doesn't matter whether they're married, whether they're living with their parents, they're attending school, whether they're even financially depending on their parents. And this rule applies to both job-based and individual plans bought inside and outside the marketplace, right? So for the job-based plans, we sometimes get calls through our helpline saying, well, I want my kid to be able to stay on my health insurance, and my employer says that that's not possible, but I heard about this law that I should be able to. Well, if that employer is only offering an employee plan and is not offering dependent or family plan, then they cannot get this rule implemented, right? It's only when the employer is offering dependent coverage. At that point, when they're offering dependent coverage, the parent can add their young adult to their coverage up until age 26. So the employer is not obligated at all to offer dependent coverage. If they do, then that parent can ask for this right to be able to keep their kid up until age 26. So the big difference with age 26 and age 29 in New York's extension. So New York, as progressive as it is, it's that, like, you know, this is great. We should also offer it and extend it to people who are up to age 29, not age 30. And the big difference is that in this case, it has to be a group policy, and it does not apply to self-insured plans. So some of you might be more familiar with what's the self-insured plan. Usually when you have an insurance company that is not, let's say, using a health plan to cover benefits, meaning they put in the money into this reserve and it pays out the claims itself. So that if that's the plan, it doesn't apply, right? But first thing, it has to be a group policy. The parent must be covered as an employee or a group member. And the requirements for the young adults are a little more restrictive. They have to be unmarried, be 29 or under, not be insured by or eligible for comprehensive health insurance, live, work, or reside in New York, and not be covered under Medicare. If you compare the flexibility of age 26, which you could be living anywhere, you could be married, age 29 it's more restricted. It does help people who may have a dependent who is high medical needs and may be unmarried and so forth. So more information is available on the FAQ at the bottom. And if you're ever in doubt, you can just Google dependent until age 26 or dependent age 29 New York extension, and you'll be able to get more information. For the next section, what I did was come up with like common questions you might get from consumers when it comes to the plan selection. And what I did is I gathered pieces of the state's presentation, again, focusing on areas where I thought maybe they were not clear. So I am going to go through them. If at any point you have questions, you should know that you can feel free to ask. So everyone is familiar with this standard form, correct? So everyone probably used this form and has many, many copies. If you are working with clients for 2015 plan options, you need to make sure you have the latest copy. And the next question is, when are you guys getting us that copy? And we will get it to you this week. One of the things you can see, and this cost-sharing standard benefit design form, I got it from the marketplace, and it was on the plan invitation. And if you notice, it has a 4/25/2014 date. If you have anything that says 2013, make sure that you're not using it to explore 2015 options, and I'll tell you why. So one of the first questions clients will ask you what benefits are covered, and they might not even know about the metal level, so you explain that. But the next question will be, what's the difference between getting one metal level versus the other? They often assume that if they get a platinum, they're going to get more. So this form is really good. If nothing else, as a resource, you can pull this form out and give a client a copy. And one of the things you can do is say that all the benefits are the same for the standard products, and we'll go into how you explain what's standard versus non-standard. And if you look at the red here, you can point out that if they see these are the benefits being covered, and it's the same list of benefits regardless of the metal level. Right? So that's reassuring the client that, yes, regardless of the metal level, you're going to be getting the same services, and you point that out, right? So the next big difference, the only variation between metal levels is the cost sharing, or to put it more broadly, the out-of-pocket expenses, right? And you can usually point out and focus them. I mean, this is overwhelming, so you want to focus their attention, and a big component is usually the deductible and the maximum out-of-pocket, right? Especially when clients are going into the silver and affordability, it's a big concern. You want to say, this is a deductible, and they may once you explain what the deductible really means, they may be like, there's no way I can afford this. I'll never be able to access services. But once you explain the maximum out of pocket and say, this is like a big protection, knock on wood, if you end up in the emergency room for 1 week, that's potentially $30,000. If you have surgery, that could be a lot more. So you want to highlight that, and that will usually refocus them in case you're losing them on the affordability piece. The big change is in green, and I need you to really focus on this because I am not sure that everyone got that from the state's presentation. So people who have income between 201 to 250% of the federal poverty level, the deductible last year, meaning 2014 deductible, was $1,750, and the maximum out of pocket, which is the MOOP, was $4,000. Well, there were a lot of, I should say, not complaints, but there was a lot of advocacy saying, you know, that deductible for someone who's making that amount of money, it's still very high. And people are opting not to get coverage once they reach that, and obviously they cannot afford the standard silver plan. So there had to be a compromise, and the compromise was we'll reduce the deductible to $1,200, but we'll increase the maximum out of pocket, which depending on your view may not be a big, maybe a good thing in general and not like something bad necessarily, because it's more likely, hopefully, depending on each person's medical needs, that it's better for them to have a smaller deductible than a maximum out of pocket because they may never reach it, right? So that's the bargain, and you want to make sure, again, that you are using the correct form. So what form not to use? So the state has this detailed forms, and we've had them on our portal, and these are still good for 2014. So in theory, if you're counseling clients for the next 2 months, this is still accurate. But this form, as you will notice, for people who are between 201, and they always get this wrong, they always say 200 to 250, but it's really 201 to 250. The deductible it's the 2014 deductible. So if you're familiar with this form, which again, we sent it around last year, we're going to try to alert the state that this is still out there to see whether they want to update this form or remove it to reduce any confusion. Again, the key takeaway message, make sure you're using the correct form. You may encounter other materials out there that you really like. Make sure that they are accurate. And the biggest change was for that 201 to 250, the deductible and the maximum out of pocket. Another question that you might get is, what is the difference between plans if they are all required to provide the same benefits? And I thought it was really good that the presentation from the state highlighted the 3 main differences, right? So while all the plans have to provide the same benefits, you are looking at some potentially very important differences, and one being plan networks. For many clients, I don't care that it offers all the 10 essential health benefits or really comprehensive benefits. If I cannot see the doctor I want, that's like a deal breaker. So it's a very important difference. The other thing could be the formulary, and same thing. If it could be the best plan, I could have access to my doctors. If the one prescription I need is not on the formulary, it's also a deal breaker. And the star ratings, which you're all familiar with, and you know, my recommendation is if the client is satisfied with the plan network and the formulary, and they're between 2 plans that, again, they're satisfied and they could go either way, obviously cost will be a factor, but assuming cost is contained, they might then look into the star rating, because that could be telling of consumer experience, and they might have a better experience. Not saying that the star rating is proof and that would be the case, but that's something to consider at the end of the day when everything else is the same. Consumers will not ask you what is the general difference between standard and non-standard plans, and in fact the information I'm just going to talk about is just more for your background. But the sub-bullet point, the second sub-bullet point may be important, and it may help you explain in case you do get asked about standard and non-standard plans. So we all know that all plans have to offer at least one standard plan, and the standard plan, for those of you who may be new to enrollment, the standard plans follow this framework, right? The non-standard plans will vary. Plans also have the option to offer up to 3 non-standard plans. And non-standard plans, it's important to remember that they have to meet the actuarial value for the respective metal level. So let me go back to this chart. Let's say that there is a standard and non-standard plan being offered at the silver level. And if I'm correct, the actuarial value, which means what the plan, the portion of what the plan would pay for cover benefits, it's anywhere from 0.68 to 0.72. The non-standard plan also has to offer that actuarial value, meaning they cannot offer a non-standard plan which in general the end value of it is less than that range, right? So regardless, you are getting more or less the same value, but you may be getting the value in the non-standard plan elsewhere, which means that to play around with that value, they may add benefits usually in the wellness area, but they can also vary their cost sharing, right? So one thing to do it is say, well, you know, we have our standard product. For my next standard, non-standard plan, I'm going to offer acupuncture, but that means that if I'm offering acupuncture as an added benefit, instead of having a set co-payment for PCP visits, I'm going to put a percentage that the client may be liable for. So they have to play around, but at the end of the day, the value to the benefit to the client should be the same. Hopefully I didn't lose you on that, and we'll go over more of that in detail. And again, regardless whether it's standard or non-standard, they have to offer the 10 essential health benefits. So in general, what is the cost sharing difference between standard and non-standard plan? And that's exactly what I was referring to. So the majority of people opted for a standard plan, and I think in part of it is because it gives you a greater reassurance that you know how much you're going to pay, because you're dealing for the most part with co-payments, right? So if we look here at the red box, you have for a primary care physician visit with a standard silver plan, and this is the example the state had under presentation, you're looking at a co-payment of $30, right? For a non-standard plan, you're looking at 20% co-insurance, and co-insurance is obviously the name for the percentage someone is paid, as opposed to a co-payment which is a flat amount, right? So if you look at this, you can see several differences. So on the one end, this non-standard plan is going to say where you're going to have to pay 20% of whatever that visit if you select a non-standard plan. But hey, we're giving you a benefit elsewhere. Your individual maximum out-of-pocket is $5,000 as opposed to $5,500. And if it's a family policy, it's $10,000 as opposed to $11,000. So there's a $500 difference and a $1,000 difference. The client really has to understand this and know what they feel comfortable with, right? So someone potentially who is very high medical needs and they know that they're going to reach their maximum out-of-pocket, and let's say they're an individual, they may be saying, well, I know within 3 months I'm going to reach the maximum, the $5,000. I'm ready to pay those $5,000 aside from my premiums. Well, they could potentially be saving $500, right? Because they know that they'll reach the maximum out-of-pocket, whether they have to pay 20% co-insurance, and that's eventually going to build up to what they're paying and so forth. Then that might be good. I mean, it's a $500 saving. I think for the majority of people you see, they may want to go with a standard plan design, which they know it's $30. I don't have to sweat it. They may say, I'll never reach probably the maximum out-of-pocket. I might be lucky if I meet the deductible. So hopefully that makes sense. What is the network difference between standard and non-standard plans? So all standard plans have the same marketplace, and let me emphasize that, same marketplace network regardless of metal level. The first year, at least here in the city, we had a lot of consumers who came back and were very upset that they signed up for Empire thinking that their doctors were within network, and they came back and were, again, very upset because it turned out that they were not. And part of it was not Navigator's fault. They had done the due diligence, and it was either because the online network provider search was not updated, and if you know Empires, it's even very hard to navigate through. I think they're fixing their website, hopefully, for this year. But it is more or less a reassurance that if you're looking at a standard plan, let's say Oscar standard plan, that whether you go with silver, gold, or platinum, you are looking at the same marketplace network. So that's important. The non-standard plan, and this is very important because we all get to pay very close attention to this. And this is stuff that at least I didn't know in the first year of enrollment, some of this stuff. So the non-standard plan may have marketplace network, a tier network, which I'll explain shortly, or a limited network, which is also known as or referred to as a tailored network. So once you're exploring the non-standard plan, again, you have to look at like the potential of a co-insurance and work with the client to weigh their options and what they feel comfortable. But you also have to look to see what type of network that specific product has. So again, the marketplace networks, you can assume that it's whatever network they are offering through the marketplace, and if a consumer is following up with a provider, they will say, I'm getting this plan through the marketplace, do you accept it? If it's a tiered network, it seems to work based on tiers, where if the consumer uses the preferred tier, let's say tier 1, that will result in less cost sharing. In which, again, I always mix cost sharing with out-of-pocket expenses, but think of like a co-payment, right? If you go to the doctors that plan or prefers that you go to, you'll pay less. If there's a second tier and you go to that one, then it's a little bit higher. So one of the examples the marketplace provided is for tier 1, you pay $20. For tier 2, you pay $30. So that's another thing to highlight to consumers. And the last one is the limited network or tailored network. And that means that those plans usually use a very specific network, and you want to make sure you make the client aware of that. Usually clients will tell you, I want Sloan Kettering, I want this hospital, and you'll narrow the searches by that. But it's possible, let's say, if it's a client in Long Island and there's North Shore and they're familiar with the North Shore LIJ healthcare system, that may be a really good plan for them, right? They work, live in Long Island. They don't expect to see any providers elsewhere. Then great. They'll have access to the healthcare system, and they will be able to get their care through that. But that's, again, the Taylor network. And the Taylor network means that it's a specific healthcare system that plan is working with. I think they also mentioned Fidelis working with the HAC hospitals and so forth. There was a big note on what if, like, I need a doctor and it's not with a network. So you can ask the plan to give you prior approval to go see a doctor that is not within network. But it's not simple. It's not like, well, I don't like any of the doctors that they have. I want to go to this doctor. You're talking about out-of-network benefits. That's just not going to happen. This is more for communities where literally there is one specialist, and that client really needs to see that specialist, and the closest specialist is like hundreds of miles. At that point, if there's a private doctor, let's say, they may authorize, again, you have to get prior approval to be able to go to that doctor. So there are parameters. And again, it doesn't mean that you don't like the doctors that they're showing and you prefer someone else. That involves more out-of-network benefits. But this is an option available. What is the deductible difference between standard and non-standard plans? This is something very important that was not highlighted, at least through the Navigator training that I went last year. standard plans have an embedded deductible, and I'll give you an example of what an embedded deductible is. But pretty much, when you're looking at a standard plan, let's say there is a couple or a family plan, right? So maybe it's husband and wife, they get a couple's plan. One is very sick, and let's say they selected a gold plan. So the individual deductible is $600, the couple's deductible is $1,200, right? You just multiply it. Let's say the husband is very sick and you know that he's going to meet the individual deductible right away. Well, in an embedded deductible, once the husband meets the $600, the plan starts paying and the client starts only paying like the co-pays, right? So that means that they don't have to wait until reaching the $1,200 in order for the plan to start paying. And that is probably more favorable to consumers than the aggregate deductible, which I'll again explain. Another benefit of the standard plan in general, for those who are selecting platinum, gold, silver, and the silver cost share reduction options, the deductible only applies to medical. It does not apply to prescription. So that's really good. A lot of times clients will say, well, what about prescriptions and how do I meet the deductible because I need to go access prescriptions. Again, if they're selecting a standard plan and it's one of those metal levels, silver and up, the deductible is only medical, not prescription. For bronze and catastrophic plans, the deductible applies to all services combined, and that includes prescription, which means they have to meet the deductible first. What about non-standard plans and the deductible? Well, non-standard plans follow the aggregate deductible. So unlike the previous example where the husband could just meet the $600 deductible and then the plan would start paying, in that case, they would have to meet the $1,200 deductible before the plan starts paying. And unlike standard plans, it is very likely the non-standard plans will have a separate deductible for medical and prescriptions. So you want to be able to look at that in case a client is considering non-standard plans. And with that said, I am not bashing non-standard plans. I think that they could be a really good option for some people. It just requires a little bit more work. And, you know, I know that Elizabeth is a fan of some of them because it may be good. Some of the non-standard plans may give you like 5 primary care visits without being subject to the deductible. So that may be great for someone who is healthy and doesn't expect to use medical services. So it can be appropriate for people. Regardless of whether it's a standard or non-standard plan, the deductible applies towards the maximum out of pocket. So I took this slide from Inning 8 from the QHP selection, which I think I should give credit to CBBP, Center on Policy and Budget, Center Budget and Policy Priorities. You know what I'm talking about because we always send those resources. So this explains the aggregate deductible and the embedded deductible. If you notice on the aggregate deductible, it's 2 parents and 1 child, so parent, and child, and they have an aggregate deductible of $6,000. The entire $6,000 must be met before the insurance starts paying, and the client can either pay a co-payment, which is the flat amount, or co-insurance, which could be a percentage. In the embedded deductible, each one has an individual deductible of $2,000. So if any of them, let's say child gets sick and they already spent $2,000, the plan will start paying after that for that child. It doesn't mean that the plan starts paying for the parent at that point. The parent has to at that point meet either their own deductible, or let's say it's, I don't want to make a sick child very sickly, but let's say it's a very, very sick child that between the deductible and the co-pays for inpatient hospitalization, that child met the $6,000 deductible. Once the family deductible is met, any parent can access services and the plan will pay. But again, the key difference is whether the plan can start paying after an individual deductible is met. how do I know if my doctors are within network? That's like a very common question, and we've talked about this, about doing the 3-point check, right? But it's always important to, especially with those clients that you think may have different expectations about or different experience, right? So if you have clients who had Aetna or a big plan and they come to you and they expect all their providers to be there, do remind them that being part of a plan is a choice that providers make. It's a contract, and they can join the network and pull out of the network, and that's a choice they make. So especially with a client that says, well, you need to guarantee me that such provider is going to be there, make sure you say, let's pause on that. I just want you to be clear that doctors can pull out. So can hospitals, right? We just heard earlier during case rounds that Oscar may not be participating with Sloan Kettering, so or vice versa. So that's a decision that they make. And you as a navigator have no control over that, and so make sure that when you encounter those clients, you clear that up. But in order to confirm whether a provider is within network, you want to do what we call the 3-point check. You want to look at the plan directory. The state did mention that they're enforcing stricter compliance guidance for the plans to report and keep their directories updated, so hopefully that will help this second year. The client should also ask the provider, and it's important that the client ask whether they take whatever plan name on the marketplace, right? Again, learning from the first year, a lot of people who wanted Empire will call their provider and say, do you take Empire? And the doctor will say, yeah, we take Empire, and then they didn't clarify that it was Empire through the marketplace. And there was a lot of confusion, so I'm hoping the second year around, the provider offices are also more in tune with what are the marketplace offerings, and they will hopefully know whether they take it or not. And that's why you're doing a 3-point check. And then obviously you can always call the health plan. It's possible that their directory is more updated than what's available online. So those are the 3 points that you can follow to advise the client. And some of that work the client can do, right? So even if the client is not very comfortable, maybe you help them with the online directory, and if you're running out of time with your session, then you give them the phone number for them to call. And some clients are really good and proactive. Others, you may have to help them a little more. So where can I find the plans provider directory or contact information? And that goes along with what I just said, that some clients may be able to do a lot of research on their own, where you're just going to send the link and they'll do a follow-up and then call you and say, I want this plan, or you might have to walk them through. So there is the only resource that I have so far, obviously, it's the website, and I think most of you are familiar with the plans you're working with and the websites and the challenges. But the state has posted this, and some of the plans are updating their websites, and it says there, and I'll show you how it looks. So you want to have this this list handy. I always download stuff from the marketplace. And part of it is because you don't know when they're thinking of revamping something, and then maybe you like the old format. As long as it's updated, you should be fine. So again, you can show them, even if you're running out of time, it's always good to show them how to do a search. And so this is the list that was available on Sunday. I don't know if there were any additional links updated. One of the things that I would recommend for you to do, and especially if you have multiple navigators in your office, is come up with your own list that you can email clients. So for example, if you're upstate, you would remove the plans from this list that are not participating in your county. And it should not be too hard, right? You just copy and paste this potentially into Excel, and you just delete and update it as links are being updated. But that would be something that would not confuse the client. Like, you don't want a client calling like from New York, calling Blue Cross Blue Shield of Western New York, right? Like, they shouldn't be exploring those plans. So make sure that you adapt this list to your needs. what about prescriptions? And at least from my experience, that's always how the question is asked, right? You're going through their plan options and they're like, the next question, what about prescriptions? Then if you have this chart, you turn to the last page, you look at the bottom, and you explain the different tiers. And usually it's more in tune with like generic, formulary, brand, and so forth. For the formulary, you know, it's the same across metal levels for the same plan, so you don't have to go into each plan. Let's say the client says, well, let me explore between gold and platinum, but let's check to make sure that that plan has the same formulary for both gold and platinum. You can assume that it's the same for gold and platinum if it's the same plan. And know that the formulary for the small business marketplace may be different, so don't assume that it is the same. I live in New York and another state throughout the year. What are my options? And so this is kind of like the million-dollar question, especially here in New York, where you have a good number of people who may, for example, spend 6 months here in New York and 6 months in Florida, right? Like they may spend the summer days here and then run out when the winter comes. One of the things to remember, and this is like the first rule, they have to be New York residents in order to access the marketplace. And that means they have to be New York residents in order to qualify for Medicaid or a QHP. And we are inclined to be very flexible on that residency requirement. But remember that there is an subjective and objective test to it. You have to intend to permanently reside in New York, right? So someone comes and says, yeah, I'm going to stay here. Or they might be honest and say, no, I'm not going to stay here. I'm just here for 3 months and then I'm moving back. That's the subjective intent, right? What's my intent? The objective intent is, for example, where have you been filing taxes? Are you a tax filer of Florida or New York State, right? And so that will tell you more or less whether they're going to meet the New York State residency requirements. With that said, you are not going to fight with someone's intent, and they can go ahead and do the application, and if they are able to complete and pass through the residency questions, then they can explore their options. You are not there to determine New York State residency. I think it's a great conversation starter to make sure that the client is aware of this requirement before you move forward. For non-emergency services, you know, there is always a question, is there a plan that someone can access here and in another state? It's possible that someone may be able to obtain prior authorization to receive non-emergency services in another state. That's something that the client would have to look into with a plan, right? And it may require a phone call. I'm not so sure how detailed or whether that information is going to be very obvious on the plans information tab or details for the plans on the marketplace. But you don't want to ever tell a client, yeah, you know, Empire or Aetna, which is not even being offered on the marketplace, it has a very broad network. Your chances are you're going to be able to see your PCP if you move to California because they also have that plan there. That is not the message you want to send. You can say that they would need to contact the plan to see if in the state they're looking into whether there are any providers and whether it is their practice to give out prior authorization. Now, if someone is really interested in something like that, you definitely want to explain that selecting a local plan is not going to be their best option, right? So, for example, North Shore LIJ, that's local. That's really like Long Island local. And I live in Long Island, so I can picture like the hospitals. If I go to California, I doubt that if I call North Shore LIJ and say, hey, I'm in Orange County, I need to go see a doctor because I'm not feeling well, this is not an emergency, can you give me a green light to go ahead? They're probably going to say, you better take a flight back to New York and come see your PCP because we just don't have providers there and we're just not going to authorize it, right? important to remember, if it's an emergency, they're covered. You could be Florida, you could be California. If it's an emergency, you will be covered. When in doubt, check with the plan. It was mentioned that Empire has, I believe, in silver and gold medal levels, a multi-state plan. And I'm going to hurry up. We're almost done. I know that it's 12:30, so bear with me 5 more minutes. Actually, I'm lying. Bear with me for like at least 10 minutes. When in doubt, check with the plan. On the multi-state plan, I always worry that this confuses people and they think, well, that's the plan I want because I can be in any state and I can access services with that plan. No, not necessarily. The reasoning behind the multi-state plan, which, many of the things, was to offer a standard plan design that anyone can go access in any state. Empire is the provider that is offering that, quote, multi-state plan option. Again, it doesn't mean that you can just go to a state and say, well, I have Empire, you should be able to cover me for non-emergency services. That's not the reasoning. In our weekly email, I'm going to send you some links so you can read up more about the multi-state plan. If you want to do it after we're done with this meeting, you can just Google Kaiser Foundation multi-state plan, and they have really good Q&A questions. Again, don't be confused by this plan option. It doesn't mean that someone can go into another state and get services for non-emergency. What about dental options? So the big thing that the state mentioned is that obviously pediatric dental is offered as a standalone product for children only, and there are going to be different dental options for single adults, 2 adults, and 1 adult plus child, and then family. And obviously standalone dental plans will be available for dependent coverage through the age 25, which is really age 26, and age 29. So that's just kind of like some highlights. I do want to emphasize pediatric dental, and this was a big surprise even for us here at CSS. So it turns out that we keep saying that part of the essential health benefits is pediatric dental, right? And we proclaim that pediatric dental is an essential and it has to be offered. Well, the meaning between it has to be offered and it has to be included in the plan is completely different. So the marketplaces were required to offer pediatric dental. It doesn't mean that the plans had it in them, right? And so pediatric dental can be embedded in the health plan, or it may be offered as a standalone plan. So let me tell you what happened with one of our cases. Father, who was above 400% of the FPL, had kids and decided to take a QHP. Because remember, we're not dealing with pediatric dental if you have Child Health Plus, because basic dental is included. So the father selected a family plan, QHP, and, within a month called and said, I cannot access pediatric dental for my kids. What's wrong with this? I thought it was included. And then we realized that that parent had to select pediatric dental through a standalone plan, and that parent had not. So that was a problem. I think most of us assumed that pediatric dental was included in the health plan, and as it turns out, the rule is that the marketplace has to offer it. It doesn't mean that it's offered within the plan. It can be a standalone. Ironically, outside of the marketplace, it is embedded into the health plan. And so that created some issues, and there was an article, newspaper article that said, I'm an adult, I don't have any kids, why am I paying for pediatric dental if I'm never going to use it, right? So that's usually the argument, and then we can, then there's the male-female issue that you can raise. Well, why am I paying for these services because I'm male, I'm never going to use, why am I paying for prostate cancer screening if I'm never going to use it, right? So same argument. Moving forward, please be aware that when you're dealing with a family that is above 400% of the FPL and they're choosing a QHP and they have children, they need to find out whether the plan they're selecting has pediatric dental. And remember at the beginning of our presentation, we had that list where it's now going to say whether pediatric dental is included or not. And if it's not included, they should be aware that they can choose pediatric dental, and probably should. I mean, it's usually dental, it's relatively inexpensive. If you have more information about how pediatric dental, there is a link there that I provided. Resources, I'm updating the federal poverty level chart that we had last year. So we will send, just so you know, I'll send you like a nice description with each of these resources and how I use them in case you're interested through our weekly alert. The premium estimator is up. The standard cost benefit sharing chart dated 4/25, which has the new deductible for people between 201 and 250, is there. This is a resource, and I put it here. This is the back end of the cost-sharing standard form. And the reason why I put it there, you'll forget, for example, that prescription is not subject to the deductible if you select a silver plan, gold, and so forth. When in doubt, just go back and read this. Or sometimes the client will say, well, how do I know? If they're selecting a standard plan, turn over your worksheet, highlight that portion, and you should be able to rely on that, okay? Other resources, there's a map of health plans by county. The documents listed, you can look at them. I don't find them particularly useful because it's just like a big sheet with X's, but you can look at those. Preparing for open enrollment, make sure to look at peak times. Give me 1 second. So this is breaking news that Carrie just brought to us, and it says, dear Navigator CAC agency, I have just been notified that the Federal Hub is down. Any new individual users coming in or existing users doing a live status change will have to come back later. So we apologize for any inconvenience. The Federal Hub is down, and luckily you are at this wonderful training, and you're not dealing with that right now. Again, I'm going to go through this quick, and I always say that, and I always say forever. If you're preparing for open enrollment, as we discussed, look at peak times, right? You want to know when you expect to have a flow. Many of you have already booked appointments for like the next 2 weeks and even months, which is amazing. Talk about, if you have multiple navigators or staff, talk about non-traditional hours and what's the availability. You want to be flexible. You want to be a cool supervisor and be mindful of their needs, and you also want to be a very cool staff member, employee, and be a team player. Have a plan for former clients and new clients, you know, just thinking, you expect the same time with a former client as opposed to a new client. If it's a Medicaid client, you allocate 1 full hour or 30 minutes. So those are things to consider. And just as a reminder, all staff members have to complete the innings, and this is for navigators. This does not necessarily apply to CACs, but I would suggest you all do it for the second year, and those must be completed prior to the 15th, which is coming up. And we send out forms where supervisors have to sign off and provide the name and date when that was watched. So this is, I will not take credit for this calendar. I asked Fleur to share kind of like her strategic wisdom, and she put up the state calendar. And what it has is, for example, it's mapping out enrollment peaks in green, right? And obviously the 15th of November, it's in blue because that's kind of like the big opening day. And some of you have said that you're going to be open and be doing potentially non-direct enrollment, but having other functions. So this can be useful. If you map out the next month of open enrollment, you can potentially see like how many FTEs you have, how many potential appointments can you schedule if you're scheduling appointments, of how many potential clients can you see if you're doing walk-ins. And this is a great visual because you are considering holidays and peak times. And again, this is a great tool to have a conversation with your staff in terms of flexibility. Another thing that you want to do is on your navigator dashboard, some of you have reported that your navigators are not listed for some of the counties, and some of the navigators have added new counties. If you go to your dashboard, you're going to, on the left-hand side, you're going to edit your account. First of all, make sure that the information on that account is the one you want displayed. Whatever is on that account is the one that's being displayed on the navigator broker search function, right? So when you go in there, if you scroll down to the bottom after you check that your contact information is correct, you're going to check Producer Navigator Profile, and this is to add counties. And you're going to click on Edit. The next screen is going to come up, and what you're going to do is you're going to hit to add multiple counties. You're going to hit the control and then select the county you want. And let's say I provide services in the Bronx and Manhattan. The Bronx will be selected. I'm going to scroll down to Manhattan. I'm going to press Control and then hit Manhattan. And let's say I also do it in Suffolk County. Then I'm going to look for Suffolk County, press Control, and Add. And that will save my history that I am providing services in those 3 counties. How do you know it went through? Well, first of all, make sure you save the changes, but go back outside your dashboard, look at the search function, and you should be able to be listed for each county. So in my example, I would search myself for Suffolk County, and I'll make sure that I came up. That's when I know that the function, the saving features of it work. And you want to do this for all your staff because we've received inquiries saying, can you please tell the state to add us for these counties, when in fact you can do it and this changes take effect immediately. So I have with me Steffi, and we just wanted to remind, this is for CNN only. I'm sorry for New York State Health Foundation that I'm subjecting you to this. We have a new media protocol, and you got this information already through email. If you don't have it, let us know. So all media requests have to go through CNN. And I'm going to turn it over to Steffi so she can provide you with additional guidance.
Hi.
Thank you.
Hi, everyone. I'm Steffi, and I guess I'm officially the Public Engagement Coordinator for the Health Initiatives Department here at CSS. And we'll sort of be helping to facilitate this process with the state. And just, this is just a general presentation of everything and an overview, but we will be sending and are really working on helping make this process a lot easier. So be patient with us during the next couple of weeks, frustrations that you might be experiencing, and we're sort of learning from everything we did this past year. But as Carolina said, all requests should go to the CNN Media email account, and that's basically, there'll be several people who are checking that account just to make sure that nothing falls through the cracks, but also, in case people are out or have meetings, that there's always that account is being accessed by numerous people here at CSS. All information on those forms should be complete. If you don't, every reporter that you're thinking of inviting, if you don't know exact contact information, just put as much information on that form as possible. And it's always better to have too much than too little, and we can always, take out what we don't think is necessary. But, please do pay attention to that, because we don't want the state coming back to us and saying that, they need more information about certain kinds of some of the fields that are on there. And if you have questions about any of it, feel free to get in touch with us. That's totally fine. Information like statistics, open enrollment numbers that you're getting, particularly if they're countywide, it makes it a lot easier for us if we have the link to the site that you're, where you're getting the information from. A lot of people are pulling the information from the New York State of Health Enrollment Report, and that's fine. It's just good for us to let them know that that's where we're getting those stats from. It makes it much easier for them to approve. And also, any kind of materials that we're giving to reporters or handing out at events, even if they have been approved, it's much better for us to just have that as part of the request that you send in. So, attach the JPEG or the flyer, even if we've seen it, just so we can send it as a package for the state. It makes the process a lot easier for us. We are working on developing a kind of list or a pool of talking points that we will get approved for the state and try to help, make it so there's a singular message and that we're all, pointing on, sort of together how we're talking about the marketplace in this next year of open enrollment. And so we are working on that as we speak, and the idea is that we will send that to the state for approval and then send that out to all of you, and you can, choose or modify those talking points as you see fit for the event or, media outlet that you're speaking with. But, that will be a lot easier instead of going through, we're really having to look at every single talking point and reviewing it in the details and making sure that, it will get through and get approved by the state. We want, it's really important that we are talking to the press and that we're doing these events and that, the state sees that role and the importance of that role. And so, we want to make it easier for you during this next open enrollment time. So we appreciate you going kind of above and beyond just doing the enrollment work. And so thank you for that. Materials, this slide doesn't talk too much about materials, but the same thing, we're looking, and I will resend out the co-branding requirements that the state did, and we're working to get some clarification from them on which logo to be using. And so that too, everything we're looking over, it's really helpful if you send us the materials in an editable format instead of a closed PDF, just because it eliminates some of the back and forth that we have to have with you. And, I can go in or we can go in and make those changes that we see fit. And then we're really working on sending everything to you to get your okay before we send it to the state. We want you to be happy with what is being submitted. So if you have questions, feel free to be in touch with us. And there's more to come on this, and we're really trying in the next, this week, probably by mid next week, to have some more clarity on talking points and stuff like that for you. Okay? Thank you.
Thank you, Steffi. So, it's a lot of work that goes into getting prior approval, and we recognize it, and we're super excited that Steffi is going to be working on this. So we'll treat her to a cookie or something in appreciation, because we want you to get things approved. And obviously, if it's even material, do not spend your time necessarily. Obviously, do your best job to submit to us a final version of it, but I'd rather you submit it, we'll provide you feedback, then you hold off on it and then say the event is next week. Because then that puts us in a very difficult position. It's hard sometimes to get, depending on what the state has on their plate, to get them. I want to do something. I want to honor your time. So I'm going to go over marketplace updates for anyone who has time to hang in the call. If as you review them, we're sending this presentation to you. If you get this presentation and you have to go now and you have questions, you can give me a call or give Leon a call, and we'll be able to answer any questions that you may have. If you have, I think it's not too much. Let me see how many more slides. It's like 2 more slides. If you have time to hang in there, we're almost done. And we didn't send this through the weekly email because we thought we wanted to explain a little bit more. And these are issues that the marketplace, the state has actually voiced from feedback from, I'm sure, from some of our navigators. So you've noticed that consumers are now getting eligibility notices on their dashboard, and that's because they put on hold on those notices. They're making changes to those notices. So I'm assuming that the state is working very fast on making sure that those go out. Clients will eventually get an eligibility determination notice. And this is kind of a challenge because let's say a client wants to appeal a decision. Usually the marketplace will say, well, we need your eligibility notice in order to appeal. So that's an issue. We're keeping an eye on this because it has repercussions for our clients. Chip transition issue. So children who are aging out, turning 19, should be able to get into a QHP, without facing a lapse in coverage, and that means that they should have gotten a disenrollment notice 60 days in advance, and that was not happening. So that should be fixed by now. So this was an issue that people reported. Navigators also have reported helping clients who have been disenrolled from Medicaid and who are not being honored or given the 12-month continuous coverage. One of the things two things to keep in mind with this. One, make sure that your client, in fact, had continuous coverage. It's sometimes the case that, you know, the marketplace asked for documentation. Maybe to no fault of your client or yours, it never got reviewed or something happened and they never got continuous coverage because they were never in that moment of like select the plan and move forward. So in those cases, you know, it's possible the marketplace will argue that they never had continuous coverage, they had just presumptive. The other thing to be aware is, and Callan-Lore, Star from Callan-Lore has pointed this out, is that it's possible the client still has Medicaid, but it's not showing when on your application. So it's in some clients we're getting eligibility decision letters where it says effective this date you no longer have it, but then at the bottom it will say you still have Medicaid, you can continue using it. So that's a problem, and that issue has been reported to the state. But when in doubt, call the account review department, and to be honest, most of the time I just bypass the marketplace and I go straight to account review. If they give you a hard time, just say that account review told you to call back, and that may help getting through. And confirm whether they still have an active Medicaid case. If you report it to me, the turnaround from my end is not as fast. I can guarantee you that you'll probably figure it out if you call account review much faster than if you report it to me. I'm happy to take it in, but again, you probably want a quick answer. There have been issues with the immigration document review process. So the problem is that when someone uploads immigration documents, there was supposed to be this automatic database matching system where it was going to be smooth. What ended up happening is that people have to actually go and do the manual review of those documents. So this has delayed the process. So if you have clients who, you know, have been in limbo because the marketplace has not checked on their immigration documents, make sure that you follow through to make sure that they review them. And that, again, might include calling account review and saying, I've uploaded this 3 times. I need you to please, at this point, take a look at those documents and clear my client, right? Empire, so this is more like upstate. So this announcement was made months ago that Empire was no longer going to offer public health insurance, Medicaid, and CHIP. And finally, you know, at one point they said that it was going to take effect October, where they were going to stop offering. Now it goes all the way to the end of the year. But clients are getting those notices, and they're being informed that they can go ahead and change plans. The key point here is that they have to change after the 15th. Otherwise, they will not be making appropriate changes, right? A second notice will go out, and especially for those who may have, let's say, Medicaid or CHIP through the old system, through the local Department of Social Services, they will also get a notice letting them know that they can go ahead and apply for Medicaid or CHIP through the marketplace. So for those people who work with this plan with Medicaid and CHIP, which is not many counties, be mindful that you may be getting clients who are coming with those notices. And you have to first identify, is this someone who just needs to change a plan because they're on the marketplace, or is this someone who applied through the local Department of Social Services and now they have to do a transition, like a new application to the marketplace. And I am done. I am so sorry for the overtime. You know, the format for this meeting was we would dedicate 1 hour of case rounds. It seemed to us that a lot of our downstate groups were, or upstate groups were joining us in the downstate groups, and they didn't have a lot to share at the end of the day, and the meeting was just getting long. There are some questions. Again, at this point, anyone is free to go. If you wrote a question and you have to go, this section is definitely optional. You can do so and then send us your question if it didn't get answered. So let's see. Okay, so I'm going to go through some questions. Do the star ratings mean anything now? Yeah, they actually do, and it's actually based on consumer feedback and provider feedback, and that's directly from the state training. That's what they said, and that's kind of like the notes I took. will this comparison chart, standard versus non-standard, be available by plan? So yes, something to that effect. The state on their presentation says that they're developing this comprehensive sheet where it will say, like, this is the standard plan. How does this non-standard plan compare to the standard plan? And the slide where I showed the copay of a flat amount versus the cost sharing, that was a glimpse of how it may look. Will the non-standard plans identify what type of network they are using in the plan details section or somewhere else? Yeah, that should be, I mean, we need to know, right? So it is my understanding. Again, all my information is based on the training that the state did, the last training. So that is my understanding. I am not obviously familiar with how it will appear. Hopefully once open enrollment starts and I am able to enroll someone and be able to get some screenshots, I can show you where that information is at. I'll definitely be on the lookout for that. So last year I knew only Health Republic offering a non-standard plan with no specialist referral required. Will that be the same next year? Some clients had big hassles getting specialist referrals. So I don't know what type of plans Health Republic is offering. I can do a little more research. What you're referring to is it's an EPO where you do not require a referral to go see a specialist as long as that specialist is within network. So again, I'll see what tools I can get you. The state has not given us, I don't know if you remember that there were like this amazing Excel sheet and at the bottom they had the different medal levels and you would be able to see the plan name, the cost, whether it was standard or non-standard. I'm hoping that they're going to issue those, and I'm hoping that the fact that they're creating this comparison charts, that they're not going to, again, that's also going to be issued and not be supplemented for it. So hopefully we'll know. Again, if it's an EPO, you do not require a referral for a specialist as long as it's within. So Greg said here, I checked, and it's through age 29, which would be up to 30th birthday, right? So that was the whole age 29. Let me verify. Greg gave me a DFS site. I will definitely let you know if I was mistaken, and I will put that in the weekly email. Again, links to the age 26 and age 29. So it's Medicaid Universal, so that people who apply through their upstate county office for Medicaid can use it down in the city. No, not necessarily. It's county-based. And what it used to be that you could transfer your case from upstate to downstate if you were moving. It's possible that depending on the plan, Medicaid plan, managed care plan you have, you may be able to access services, but you have to check to make sure. Obviously, in an emergency, you can use it. But if someone who's moving from upstate to downstate, they will select a plan based on their county. And I had actually that question because, for example, the client may live in New York City and spend a few months upstate because their mother lives there and they want to be able to use their Medicaid in both parts. They always have to check to see if there's a provider that would accept that specific managed care plan. But it's not it's not universal per se. Okay, so this is like an interesting question. So in our first year, one hospital has on their website, they take Fidelis, for example, but they only take Medicaid, Fidelis, not anything from the marketplace. By the time the client went to her doctor, it was too late to change plans last year. She is on my schedule to sign up for a new plan this year. It was very confusing for people here because when we called the hospital billing department, they did not understand the difference between Medicaid and, say, a silver plan. That is correct. So you want to do a 3-point check, unfortunately, right? So the question is, for a provider who may not know the difference, and that's an issue already. One, on the website, and I can go back to play around with Fidelis, but I believe you have to select Fidelis and you have to specify whether it's a marketplace product or Medicaid product, and that should automatically give you the correct network. The other thing that I would do is call the plan in advance, or call the plan at some point before selecting that plan, and say, my client is eligible for Medicaid. Does your Medicaid product have such and such doctor within network? You always want to specify which type of product, right? Even for Child Health Plus, the pediatrician might not take Medicaid Fidelis, but they might take Child Health Plus Fidelis, right? So every product has to be specific to make sure. I hope that helps. It says here, please remind everyone that multi-state plans do not mean that they have coverage in more than one state. It means they do not cover abortion and have nothing to do with that area. So, yes, that's great. And remember, multi-state, misnomer, it doesn't mean that it's covering in multiple states. It's a standard design created by the Affordable Care Act. I'm going to be happy to send you guys Q&As that you can follow up on. Out-of-state students. If a student is on Medicaid in another state or county and might need to access services that are non-emergency in the state where they are attending school, in addition, their parents are still claiming them on their taxes, is there any way to get them enrolled into Medicaid managed care in the state of the school they are attending? So that's a decision, a residency question that you're going to have to answer, that the student has to answer. So it's fine where if they're Medicaid eligible, who cares who's claiming them, right? It assumes that based on the income they're eligible, and they would have to report the parents' income, right, if they're being claimed and so forth, because they're a dependent. Anyways, there's some specific rules. But what that student would do is they would answer the residency questions, and if they are deemed a resident of New York State, regardless of how their parents claim them in their taxes, they should be able to get a managed care plan here, a Medicaid managed care plan, or Medicaid here. Now, they would face the same issue that at some point they have to decide where they're going to get their primary care. Unfortunately, unless someone has a plan with out-of-network options or one of those major network plans, the consumer is going to face the same issue. If they go back home and get sick over there, it will only cover, I mean, Medicaid will not even necessarily cover them, right? It's a state benefit. If it's a QHP, they will be covered. So, again, the answer is if they meet the state residency requirements, sure, they can go ahead and apply, but they're going to face the same issue if they go back home. At some point, they have to make a decision where they spend most of their time and where it would be most beneficial. Will there be an e-certification, like an official certification? I don't think so. You know, your supervisor is signing off that you've watched all the innings, and so that's as good as it gets, I think.
For now.
For now, unless we get additional information. Same question, how will we notify of a recertification? Again, you just attest that you saw them all. Once the state reviews that you saw them all, it means that you're just not in trouble, probably. Okay, that's it. Unless there are any questions, we are going to wrap this training.
Most people are there. It's 47 people. Well, we have like
Okay, so we were just checking whether we had any human beings at the other end still listening to us, given that we went a little bit over time. We'll manage, or I will manage my time more wisely. I'm big on respecting everyone's time. Hopefully this was useful, and Leon will say the final remarks and go vote.
All right. Yes. Wow, what a meeting. What a meeting. A lot of information, and hopefully everyone is ready now for the open enrollment. Doors open up November 16th. We open those gates, and the people will come, and we already see that, as we heard today, a lot of people already booked up for that first week, so really excited about that. So we're going to meet again. And I'm pretty sure at that point, a lot of people have stories to share because open enrollment have already started. So we'll meet again next month in December. Everyone, thank you for your time. Enjoy the rest of your day. And please remember the polls close at 9 p.m. today. So if you're ready to vote, please get out there and vote for the candidate of your choice. Thank you, and enjoy the rest of your day.